Welcome to our deep dive. Today we are looking at a massive stack of ATI pediatric nursing prep materials.
Yes, specifically focusing on chapters 24, 25, and 26.
Right, the renal, genitourinary, and reproductive systems. Which, usually when we look at medical texts, there is this expectation of precision, like engineering almost.
It is comforting when diagnostics are binary, right?
Yeah.
We like things to be easily categorized, especially when, you're trying to memorize them for a high-stakes exam.
Exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, yep, there it is, broken.
Yeah, very cut and dry.
But then you step into the world of pediatric nursing, and suddenly that x-ray machine feels like it's completely broken. I mean, we are looking at a diagnostic landscape that is just incredibly murky.
Oh, it's the absolute definition of diagnostic muddy waters. And if you are listening to this right now, chances are you're a dedicated nursing student prepping for your ATI RN Pediatric Nursing Proctored exam.
We feel your pain.
We really do. We know that studying pediatric renal and GU disorders can feel incredibly overwhelming. You're just staring at this mountain of seemingly unrelated symptoms, lab values, medications.
It's just a wall of text.
Right. But by the end of this deep dive, you won't just be memorizing flashcards.
Yeah.
Understanding the actual why behind the symptoms makes the exam questions so much easier to navigate.
Yeah, we're going to extract the most important nuggets of knowledge from these sources, because once you understand the precise mechanical and inflammatory breakdowns happening inside that pediatric patient,
It gives you a massive edge on your exam.
it really does. Okay, let's unpack this. We're going to start with chapter 24, looking at the most common pediatric GU issues you'll encounter.
Right, so both in clinicals and on the exam.
Yeah, exactly. This is when the normal process of urination goes wrong, not because the kidneys are failing, but because of behavioral or functional glitches or infections, like enuresis.
Right, uncontrolled urination. And the text divide this into primary and secondary enuresis.
Which I think is easier to understand if we compare it to, like, a smartphone's notification system.
Oh, I like that analogy.
Yeah, so primary enuresis is like a phone where the push notifications were never turned on in the first place.
The child has never been free of bedwetting. The neurological connections just haven't matured yet.
Exactly. But secondary enuresis is different. That's a phone that was working perfectly, notifying you every time, but suddenly it got muted after a really stressful software update or some major life event.
That perfectly validates the clinical parameters we see in the sources. To even diagnose enuresis, the child must be at least 5 years old.
Because before 5, the notifications are still being programmed, right?
Exactly. And the inappropriate urination has to happen at least twice a week for a minimum of 3 months.
3 months. Okay. And the ATI materials also highlight this really fascinating diagnostic formula for figuring out functional bladder capacity.
Oh yeah, the age plus 2 formula.
Right. You take the child's age, you add 2, and that gives you their expected capacity in ounces. So, like, an 8-year-old should be able to hold 10 ounces.
Which is such a helpful metric for nurses to know. And what's fascinating here is how the medical interventions directly target that physiology when behavioral conditioning doesn't work.
Like using alarms or limiting evening fluids.
Right. So pharmacologically, we might use desmopressin acetate. It's an antidiuretic that literally tells the kidneys to just reduce urine volume overnight.
That makes sense.
Or we might use imipenem hydrochloride to actively inhibit urination.
Wait, let me stop you there, because if I see an order for imipenem, my brain immediately flags it as a tricyclic antidepressant.
Right, it is.
So if a 7-year-old is wetting the bed, why on earth are we giving them a heavy-duty psychiatric medication?
It's a great question. We're actually targeting the drug's side effect profile. Imipenem has strong anticholinergic properties, so it relaxes the bladder muscle and tightens the sphincter.
Oh, okay, so it artificially rebuilds that control.
Exactly. Though we have to emphasize the critical nursing action here for the exam. Because it's a tricyclic antidepressant, you must constantly monitor the child for suicidality.
Wow, okay, that is a huge red flag to watch out for.
Absolutely.
So if a child comes in with a sudden onset of secondary enuresis, should we immediately assume it's an emotional stressor, like a divorce or a new baby in the house?
Jumping straight to psychological stress is a trap. A physical cause must be ruled out first. Specifically, you have to rule out a urinary tract infection.
A UTI.
Yeah.
And UTIs in pediatrics are just wild. Because if an infant has a bladder infection, they obviously can't say, hey, it hurts when I pee.
Right, they can't localize the pain.
And their symptoms are so counterintuitive. You're looking at irritability, Poor feeding, throwing up, maybe a fever, foul-smelling urine. Like, why are they refusing a bottle if their bladder's infected?
It's because infant immune systems just dump everything into a systemic response. GI distress is super common for any infant infection.
Okay, but older children will present more classically, right?
Yeah, pain, frequency. But also, watch for facial swelling, pallor, and back pain in older kids.
Good to know. And to test for that UTI in an infant under 2 years old, we can't just stick a cotton ball in a diaper, right?
No, absolutely not.
Yeah.
The gold standard for testing in that age group is a sterile catheterization or a suprapubic aspiration.
A suprapubic aspiration. Taking a needle directly through the abdomen into the bladder. That sounds so intense.
It does, but it's the only way to bypass the normal skin flora and get a truly sterile sample.
Right. The diapers are just covered in bacteria.
Exactly.
Okay, so that transitions us smoothly into Chapter 25, moving from functional and infectious issues to the actual anatomical plumbing.
Right. If the software and the fluids are fine, we have to check the hardware.
The structural disorders, and the prep materials focus a lot on the urethral opening being in the wrong spot, hypospadias and epispadias.
Which students get mixed up all the time.
Yeah, so my mnemonic for the exam is hypo means below, so that's on the ventral or underside surface, and epi means upon or above, so that's the dorsal or top surface.
That's a great way to remember it.
But here's my question. Why don't we just fix these structural anomalies the moment the child is born?
Well, there's a very specific psychological and developmental timeline for this.
Oh, really?
Yeah. Ideally, the surgery is performed between 6 to 12 months of age. But it definitely needs to happen before 3 years.
Why before 3?
If we connect this to the bigger picture, early intervention minimizes emotional trauma. Between ages 3 and 6, children become very aware of gender and genital differences.
Ah, I see. So you want to fix it before they really develop that body image awareness.
Exactly. It preserves normal sexual and urinary function without the psychological scarring.
That makes total sense. Now, another big structural one on the ATI is bladder exstrophy,
Yes, that's a critical one.
where the bladder is literally exposed outside the abdomen. So as a nurse, my instinct is to cover that up immediately.
You do have to cover it, but how you cover it is highly testable. The critical nursing action is to cover the exposed bladder with a sterile, non-adherent dressing.
Okay, non-adherent, like plastic wrap.
Yes, sterile plastic wrap or a dressing soaked in sterile saline. Do not use dry gauze.
Because it would stick to the tissue and rip it off when you change it.
Exactly. Massive trauma.
Got it. Okay, moving on to thymosis. This is the inability to retract the foreskin in infants.
Right. And the golden rule here is never forcibly retract the foreskin.
Even for cleaning.
Even for cleaning. It causes micro tears, which scar and make the problem permanent.
Ouch. Okay, noted. And what about testicular torsion?
That is a true medical emergency. The testes hangs free from its vascular structures and twists, cutting off its own blood supply. It needs immediate surgery.
Okay, so for all these plumbing surgeries, what's the post-op care look like?
You'll be giving anticholinergics to decrease bladder spasms, which are very painful. And importantly, no tub baths for at least 1 week.
No tub baths, just sponge baths. Keep the dirty water out of the surgical site.
You got it.
Okay, so let's transition from the lower structural tract up into the actual kidneys, Chapter 26.
Ah, yes. The renal heavy hitters.
This is the ultimate compare and contrast section that nursing exams just love to test. We're looking at acute post-streptococcal glomerulonephritis.
Or APSGN.
Right, APSGM versus nephrotic syndrome.
These two are so frequently confused.
Okay, so I always compare the glomerulus to a coffee filter.
I love this analogy.
Yeah, so in nephrotic syndrome, the filter has these giant tears in it. It's ruined. So it's letting all the valuable coffee grounds, which in our body are proteins like albumin.
Right, the essential proteins.
Yeah, it lets them slip right through the filter into the pot, which is the urine.
And that altered membrane is the whole problem. Because that albumin passes into the urine, it drastically decreases the blood's osmotic pressure.
Because albumin holds the water in the blood vessels, right?
Exactly. So without it, fluid just leaks out into the tissues.
Which means massive edema.
Massive generalized edema, severe ascites in the abdomen, and you might even see Merricky lines on their fingernails from the protein loss. Plus, the urine dipstick will show like +2 to +4 protein.
Wow. And the texts also say nephrotic syndrome causes hyperlipidemia. Why does cholesterol go up if the kidneys are leaking protein?
Well, the liver senses that protein dropping, so it
Yeah.
panics. It starts overproducing lipids trying to compensate.
That is wild. So how do we treat it?
First-line medication is prednisone, a corticosteroid.
But if we're giving a child heavy steroids, we're suppressing their immune system.
Exactly. So nurses must intensely monitor for infection.
Okay, so that's nephrotic syndrome with the giant tears. Now contrast that with APSGN.
Right.
Going back to the coffee filter, in APSGN, the filter doesn't have tears. It's just totally inflamed and clogged with junk.
Specifically, immune complexes from a previous infection.
Right, so everything backs up, and the liquid that does squeeze through looks murky and dark.
It occurs 1 to 2 weeks after a group A beta hemolytic strep infection, usually in kids age 5 to 8.
Wait, so strep throat causes kidney failure?
It's the antibodies. The immune system fought off the strep, but those leftover antibodies clog up the glomerular filter.
That is crazy. And because it's clogged, you get oliguria, like hardly any urine output.
Right. And what does come out is cloudy tea-colored urine from the crushed red blood cells squeezing through.
Here's where it gets really interesting, though. Because how do you prove they had strep weeks ago if their throat is fine now?
You check the antistreptolacin O, or ASO titer. It proves there was a recent strep infection.
And what about the swelling? Is it massive like nephrotic syndrome?
No, the edema here is usually facial and periorbital, so around the eyes. And it's notably worse in the morning.
Okay, so for nursing care, we have to monitor daily weights, right?
Yes, incredibly strictly, on the same scale with the same clothes. And managing their hypertension is crucial because of all that retained fluid.
Makes sense. Okay, we're moving from inflammatory conditions to complete systemic breakdowns, the critical renal emergencies in the ICU.
These are terrifying situations.
Let's start with hemolytic uremic syndrome, or HUS. I have to admit, I struggled with this one. Wait, so a child eats an undercooked hamburger, and suddenly their red blood cells are destroying their kidneys.
It sounds like science fiction, but it's a very real, very dramatic pathology. HUS is characterized by a triad: acute renal failure, hemolytic anemia, and thrombocytopenia.
And it all starts with toxins.
Yes, often from E. coli. The toxins enter the bloodstream and literally shear the red blood cells apart.
Oh, wow.
And then all that cellular debris just completely clogs the kidneys.
So that's why client education is so massive here.
Absolutely. You have to educate parents to cook ground beef to at least 74 degrees Celsius or 165 degrees Fahrenheit and avoid unpasteurized apple juice.
Right, prevention is everything. But what about broader acute renal failure, or ARF?
So ARF has many causes, but in pediatrics, pre-renal causes are by far the most common.
Pre-renal meaning the issue is happening before the kidneys.
Exactly. Usually it's severe dehydration from diarrhea or vomiting. The kidneys just aren't getting enough blood flow.
And when the kidneys fail, the electrolytes go completely out of whack.
This raises an important question. How do we medically manage these dangerous electrolyte imbalances?
Well, for severe acidosis, the text says we use sodium bicarbonate.
Right, to act as a buffer.
But the hyperkalemia treatment threw me. They use IV glucose and insulin together. I mean, if a kid has high potassium, why are we giving them insulin?
It's fascinating. We actually use insulin to force the potassium back into the cells. It shifts it out of the bloodstream where it's dangerous to the heart.
Oh, I see. And then you give the glucose so you don't accidentally send them into a hypoglycemic coma.
Exactly. They work perfectly together to stabilize the patient.
Man, what a journey from the plumbing of the lower GU tract to the micro-level coffee filters of the kidneys.
You've really covered a massive amount of pathophysiology today.
So what does this all mean? For the nursing student listening right now, it means you're ready to look past the symptoms and actually treat the underlying physiological breakdown.
Absolutely. Mastering these details doesn't just pass exams. It honestly saves the lives of very vulnerable children.
Yeah. And I want to leave you with a final thought to mull over. Consider how pediatric renal damage, like even from something as common as childhood strep throat, can alter a person's cardiovascular and renal health trajectory for their entire adult life.
That's a profound point.
Right. Like, how might pediatric nurses actually be the ultimate preventative cardiologist?
I love that perspective. It really shows the long-term impact of this care.
It really does.
Like-
Well, keep studying, and we'll catch you next time.